Proposed amendments to the CareShield Life and Long-Term Care Act seek to introduce amendments that redefine the circumstances under which the scheme applies to certain individuals and to provide for the service of documents related to the Act. I support the bill, but will share some remarks on the first element dealing with the scope of coverage of CareShield Life. I'll begin with elements close to the specificities of this present bill before moving on to more general issues of coverage. Clause 3 amends Section 6, Part 1b to automatically enroll new citizens or permanent residents, PRs, born before 1980, or who became citizens, or those who became citizens or PR after October 2020, so long as the individual was not already severely disabled. This would effectively compel enrollment for those aged 45 and older into the scheme if they happen to have recently altered their immigration status. In contrast, long-time citizens and residents remain grandfathered on the older, albeit discontinued, Elder Shield scheme. This effectively creates a disparity between older new citizens and residents and existing ones if the latter had not opted into CareShield Life. Does the ministry have any concerns over whether this disparate treatment might become an issue in the future? If so, would it not be better to compel all to move over to the new scheme? Relatedly, these amendments, along with those in Sections 6, Part 4b, exclude those who are severely disabled from the scheme, unless approved by the Minister. I understand the economic rationale for such exclusions. We do not wish to create a case of adverse selection, where those enrolled in the scheme are all already disabled, thereby rendering the risk-sharing aspect moot. Still, it remains a moral responsibility for society to take care of those that are already disabled. Now, I understand that the government does have in place a multi-pronged approach for supporting such individuals. This includes taxpayer-funded, means-tested subsidies and grants, other supplementary insurance schemes, access to self-funded healthcare savings, and a last-ditch safety net. Still, I would appreciate a comparison of how those without CareShield Life coverage would fare relative to those who would otherwise be reliant on piecing together these disparate sources of financial support. Moreover, it is unclear how the Minister will exercise the discretion afforded to him. Are there specific conditions which will lead an individual to be approved or excluded? Clauses 7 and 8 formalize the 6 activities of daily living, for which an individual must require either maximal or total assistance in 3 before they are considered severely disabled and thereby qualify for CareShield Life payouts. I will start by noting the slight difference in the 6 categories defined by MOH relative to other standards out there. In particular, our basic ADLs include a separate mobility function, which I believe is a significantly higher bar than simply transferring. It also strikes me as a greater hurdle than either hygiene and grooming or continence, which are used by the World Health Organization's International Classification of Functioning, Disability and Health, or the CAT Index, respectively. Perhaps more important is that these 6 ADLs remain an incomplete representation of an individual's ability to function adequately in a modern community. They mainly describe aspects of physiological self-care, but exclude important ancillary aspects of psychological or social behavior that are nevertheless necessary for independent living. These are otherwise known as instrumental ADLs or IADLs. While I accept that it's not possible to cover every possible aspect of effective functioning, I believe that it is nevertheless important to recognize that such instrumental ADLs can be materially affected after a critical illness, which is precisely the sort of circumstances where one would hope insurance protection kicks in. Moreover, dignified living in modern Singapore virtually requires that individuals be able to perform certain IADL tasks, such as preparing or purchasing meals, handling money, and using transportation. The lack of mention of these activities in the evaluation criteria for disability coverage under CareShield Life is even starker when such metrics are already being accounted for by certain local medical support organizations, such as Dementia Singapore or the College of Family Physicians. It is also a notably bipartisan concern, having been raised in the previous term of Parliament by members from both sides of the House. Admittedly, including all IADLs in coverage will likely mean a larger risk pool, which could in turn materially raise premia. This is an empirical question, but even if we do not go the full extent of including all on the list, which typically includes up to 8 distinct tasks, activities such as communication, transportation, and medical management appear to be functions that are much more necessary for living in a modern city-state such as Singapore. Now, a related concern is whether the need for maximal or total assistance in 3 activities is more reflective or indicative of severe disability than, say, moderate assistance, but in 5 distinct activities. Indeed, using an index approach, it is possible to construct outcomes where those who qualify for CareShield Life are severely disabled might even score higher on an index of daily functioning than someone who would have scored lower. If we take the notion of disability assessment seriously, we should perhaps move away from the current binary outcome, like the inability to perform at least 3 ADLs, toward a more clinically corroborated approach, which relies much more on index scoring. The use of indexes is relatively widespread in jurisdictions including Australia, Japan, the United Kingdom, and the United States. Let me move on to more general issues about CareShield Life, which were flagged in the 2015 Review Council report but not yet directly addressed in the present bill. These have, directly or indirectly, been informed by my interactions with residents in Sengkang that have faced difficulties associated with the current operation of the scheme. The first concern is related to the optional enrollment process for those born 1979 or earlier. One issue is whether the 60-day free look period may be too brief for those who enroll to decide on whether they wish to remain on the scheme permanently. Relatedly, some appear not to have fully understood what they are truly getting themselves into in terms of what their ongoing premium payments. Now, while I understand the underwriting principles require that participants be ultimately locked in, I wonder if the free look period may be extended to a longer duration, such as 3 months. Similarly, would it be possible for enrollees to opt out within, say, a year, perhaps with some penalty? After all, while optional exits would undeniably mess with actuarial calculations, opting out tends to be far less distortionary for the long-run financial viability of the fund compared to unrestricted opt-ins. Second, the government has assured the public that they will ensure that no one will lose coverage due to an inability to pay their premiums. This is something the SMS Co had reiterated earlier on several times. Now, this is important not least because cost of living pressures, while abating over the past year, remain a major concern for many Singaporeans. And the last thing we'd like to do is to saddle our workers with yet another cost increase at a time when they're also simultaneously concerned about job security. Will the ministry clarify what proportion of current participants receive premium support and what the process of accessing additional premium support entails? In particular, would this support kick in the event that they lose a job so that they do not also risk losing their insurance coverage at the same time? Third, I would like to know whether, in practice, CareShield Life will be directly run by the Central Provident Fund Board under the direction of the Ministry of Health, or if it will be outsourced to a third-party private insurer, such as income insurance, to administer. I ask this because, to my knowledge, other insurance programs run by the CPF board, such as the Dependents Protection Scheme, DPS, or the Home Protection Scheme, HPS, appear to be administered by companies such as Great Eastern and Income Insurance. I have encountered instances where residents expressed dismay about how they were caught unaware that there were lapses in the coverage of either the DPS or HPS due to insufficient funds remaining in their CPF ordinary accounts. This was already discussed this morning by Minister Tan See Leng. That said, it's possible that, while it's possible that some may be surreptitiously trying to reinstate their insurance plan ex post facto to make a claim after an untoward event, there is, in fact, another plausible reason. Because premiums had previously been automatically deducted from their CPF OAs, they did not meticulously track the need to routinely make payments. They were thus unaware when, due to inadequate OA balances, that their coverage had lapsed. Moreover, because they were expecting a contractual relationship with the government and not a private entity, they then proceeded to overlook reminder mailings sent by these companies. For this reason, I believe that it would be useful to ensure that should CareShield Life ultimately be outsourced to a private insurer for administration, that correspondence pertaining to the scheme still come directly from CPF board, or at the very least feature a CPF board logo prominently in the letterhead. This will ensure that policyholders treat such correspondence seriously. At the same time, CPF must assure the public that despite being managed by a non-governmental entity, claims will continue to be evaluated not just with an eye toward prudence, but also compassion and common sense. This will ensure that the hard-won trust of Singaporeans in the institutions of government is not inadvertently squandered by private corporations that are chasing a bottom line. Mr. Deputy Speaker, the recent ruling by the district courts against income insurance over its wholly unreasonable, I quote, conduct in denying insurance claims by 78-year-old Kowa for accident-related damages is a reminder that our pronouncements of a we first society must ultimately be backed by concrete action that is consistent with that aspiration. Now, this is hopefully an isolated case. Still, we must understand that the promises of CareShield Life to help the most vulnerable in our society to continue living a life of dignity after a devastating accident will only go so far as this is truly realized in practice. If support is too meager, too perfunctory, or too grudgingly provided, then this promise will ultimately ring hollow.
Mr. Ng Chee Meng, Ms. Joan Pereira, and Dr. Chu Pei Ling asked how we can keep premiums affordable even after this transitional support ends. Now, beyond the transitional support, MOH will continue to provide means-tested premium subsidies for lower and middle-income policyholders. This will offset up to 30% of their premiums. Premiums will also continue to be fully payable by MediSave, with additional support provided to those with lower MediSave balances. Recently, in July 2025, the government provided MediSave top-ups of about $320 million to 600,000 Singaporeans. The government will also be introducing the Match MediSave scheme from 2026, with 1:1 government matching for voluntary cash top-ups of up to $1,000 per year for those with lower MediSave balances. Lastly, there is also the additional premium support for policyholders, which Associate Professor Jamus Lim asked about. We will extend invitation to policyholders who are unable to afford their CareShield Life premiums, even after subsidies and family support, to apply for this additional premium support. I would like to assure this House and reiterate once again that no one will lose CareShield Life coverage due to an inability to afford premiums. Third, on simplifying processes and improving access to financial support. Now, before I elaborate further, let me just first clarify with Associate Professor Jamus Lim that CareShield Life is administered by the CPF board and not outsourced. We fully acknowledge the challenges faced by caregivers. We are committed to improving the user journey for care recipients and caregivers, and ensuring a citizen-centric experience that allows residents to get support in a timely manner, as Ms. Miriam Jaffar has shared. Since CareShield Life was launched, we have doubled the number of severe disability assessors island-wide, from over 300 at launch to now more than 700 assessors. More general practitioners in the community, therapists and nurses are being trained, and every public hospital now has in-house assessors. We have also expanded the number of assessors who perform house calls to improve access and convenience for policyholders. MOH and AIC will press on with efforts to expand our assessor pool.
Thank you, Speaker. Two follow-up questions from me. The first builds on the question by Ms. Hertingrue about gender-neutral data. I appreciate SMS Ko's explanation that CareShield is a brief program, but we have a predecessor program, ElderShield. Although it's different, I wonder whether that longer history will afford us the ability to differentiate between the gender the gender data that Ms. Her requested, and if you don't have that on hand, perhaps if we should be filing a PQ on this. My second question also riffs off a clarification by Ms. Miriam Jaffar about the all-or-nothing approach. I understand his clarification that we don't want to have a system where it's gamed, but one point that I raised in my speech was about an index approach, either a CATS index or modified Barthel's index would assign scores that differ according to whether it's a moderate disability or a severe disability, and then map those to an ultimate score. And that kind of scoring approach is purely objective and may rule out the possibility of this kind of gaming of the system.
SMS Koon.
So I think the gender-related claims data, like I said, we don't have enough mature data to share, even if we look at some of the ElderShield claims from before, because that's a different construct and at a different time point where not all the individuals may give us good data at the moment to project forward for CareShield Life. So we can take a look, and if there are data to share, we will do so at maybe a future sitting. On the scoring system, the crux of the issue is whether we want to allow those with moderate, maybe even mild disability to be included. And that means expanding the scope of coverage. Because if you are taking a graded approach, it means that you are trying to define those who are lesser than severe disability according to today's ADL definition to be accessible for claims. That means broadening the coverage to a wider pool of people, which must mean that the payouts must increase, which must mean that the premium loading on existing cohorts must go up. So CareShield Life Council did consider whether we should broaden from beyond severe disability to those with more moderate disability. But I think in the end, the Council take the approach that that would mean that there will be policy premium impacts on the rest of the policyholders and potentially make it less affordable to more Singaporeans. And as I mentioned in my speech, the Council's decision is that to take a balanced one, where as a basic level of protection for all Singaporeans, they want to make this affordable and more broad-based, rather than opening up to a lot more claims and making it far more difficult for especially those in the lower income to be accessible. And for those with milder disability, generally you can imagine that their care needs will be much lesser. In which case, our approach of strengthening subsidies at the care delivery setting would make many of these care more affordable already and available to those with milder disability. So it is not just trying to solve the problem with one tool, but looking at the multiple layers of support we have by, first of all, making the overall care cheaper through subsidies, through grants, so that the need to even tap on CareShield Life for milder, maybe to moderate disability will be much lesser as well.
Thank you, Speaker. I do not wish to belabor this point too much, but just allow me to clarify that actually it could, using an index approach, you do not necessarily need to expand the coverage to individuals purely facing mild disabilities. I'll give you an example. An individual reporting maximal assistance in 3 areas, let's say toileting, bathing, and dressing, for instance, but being able to fully perform all other functions. So this is someone that would fully qualify for CareShield Life would score 80 points on the modified Barthel Index, which is actually a higher score than another individual who requires just moderate assistance in, for example, transferring, mobility, dressing, and feeding, and yet be able to perform other functions independently. So my point is that when you use a scoring system, it is not necessarily the case that you immediately will expand to a much larger pool of individuals, but actually just those individuals that truly need that assistance through disability.
SMS Koon.
Thank you, sir. No, I understand there are different assessment tools in the market in assessing disability, but what we are choosing to use is something that is widely adopted at WHO, in the EU, widely used by insurers. So it's also something that many of our clinicians and doctors are familiar with. And I think it's something that we want to do that is aligned with international practice, that is also easy and convenient for our assessors and our clinicians to use, rather than just put in different matrices that actually ends up promulgating different tools and creating some confusion. But I think we both agree that we should try to make sure that the scheme is sustainable by, at this moment, as far as CareShield Life is concerned, to limit the support to those with severe disability. And of course, those at the margins, we will take a compassionate approach. If they require care that cannot be claimed through CareShield Life, but for which they need further support, we have other means to help them to assess those care as well. And that's the ultimate thing, to make sure that regardless of the severity of your illnesses or your disability, care is always accessible, and if need be, other forms of support can come in.